So actually, Dr. Datilis and I sometimes do partner in certain projects, and my goal is to either, I'm a cornea surgeon and a cataract surgeon, so I'm a clinician, and most of my time is actually clinical research rather than the basic science research. So this is the clinical part of the talks. And one of our goals is either he finds a vaccine or I find a machine that does the surgery. That way we take the human element out of it. So hopefully that's the goal for us, to try to eliminate the blindness due to the cataract. How many clinicians are in the room right now? Okay, so that's pretty good. So one thing that we have to, that my talk is about femtosecond-laser-assisted cataract surgery, or femtosecond laser. Whenever there's a new idea that is presented to anyone, it depends on which angle you look at it. It might be like an incredibly brilliant idea, or it may look like a really silly idea. And a lot of times now, in a lot of the pharma and a lot of places are singing the praises of this new technology as if it is the brightest idea since sliced bread. And a lot of us as clinicians, we are like, is this really something that I want to invest in, or am I going to be burnt by this technology? So where do you stand? There are a lot of challenges from cataract surgery. I actually just came in from doing quite a few surgeries this morning. But a few things that really happen at the time of the cataract surgery. So cataract surgery has really 8 major steps in doing the cataract surgery. Number one, you actually have to have access to the cataract. So you have to go through the cornea, and that's where you have your corneal incision. Number two is you have this corneal incision, depending on how good you are, depending on how frequently you have, and it's a super sharp blade. So it is really not optimized, and it can leak, and thus from the leakage, it can potentially increase the possibility of infection. At the Wilmer Eye Institute, our infection rate is rather low. It's about 1 in 3,800. So it's really the endophthalmitis rates, as we call them, after cataract surgery are fairly low. We like them to be 0, but they are not quite. And endophthalmitis can be very devastating. The second thing that you have to do is a capsulorhexis, which means that the cataract is in a box, and you have to just make like the tissue paper. So you have to make an opening, a circular opening, right in the beginning of the front of that box. And that's how you actually get access to the lens. And then you have to break the lens. So the capsulorhexis, if you have ever tried to do 10 perfect circles by hand, you'll realize that you're not really perfect. And sometimes it is off-center, sometimes it is lopped, and it is oval instead. And that can lead to a lot of capsular tears and actually the lens dropping to the back of the eye, and then you need a vitrectomy or a retina surgeon to help you with the surgery. The lens fragmentation, you can have a lot of ultrasound power that you may use, and that leads to actually decompensation of the cornea. As a matter of fact, cataract surgery used to be the leading cause of corneal failure back in the 90s, and that is pseudophakic bullous keratopathy. Luckily, with the technology and with improved surgical techniques, that has reduced. On the other side, internationally, we, as Dr. Datilis said, in some of the countries, there are only about 10 eye surgeons to operate on a population of 10 to 15 million. So you really, the population is producing more cataracts than any of our surgeons can actually operate on. So no matter how many surgeries we do, there are more surgeries, cataracts that are being created than we actually can do. And therefore, it is the leading cause of blindness. And because of surgical techniques, there can be a lot of surgical complications, especially in underserved areas. So this is basically what we are talking about, the femtosecond laser, and what it does is that it makes a perfect circle each and every time that is round, that is centered. And that is what the companies are telling us it does. The corneal incision itself is perfectly symmetric and whichever degree you want it to be. And lastly, you can image the lens and you can soften this lens so you can practically actually just suck it out without using any ultrasound. And this is just basically the bigger picture just to show you how it is. And this is what the laser is doing. It is basically creating the main corneal incision so that you can go through the main wound. And then there's a small instrument that you have to come in here to manipulate the lens while you're doing the cataract surgery. It corrects a little bit of astigmatism. And this right here is what we call the capsulotomy. So here is where the start of my talk. So the start of my talk is Is femtosecond versus conventional phaco, is it safer? Is it better? Is it cost effective? And where are we heading? And this is really mainly for the clinicians to help you decide on, is this technology for me or is it not? So right now in the market there are actually 5. In the United States there are 2 leading ones, which is the LensX and the Catalyst. These are the 2 competing. They have the biggest shares in the market currently. All of them have been FDA approved to do cornea wound and limbo relaxing incisions, continuous capsulotomy, as well as lens fragmentation. So the femtosecond laser platforms, the only 2 major differences between the different lasers is actually 2 things. One is what they use to have it contact with the eye. Some of them use a contact lens or a curved interface, and others they use a fluid bath typically. Initially, there was significant differences between the curved interface and the fluid bath, in the sense that the curved interface increases the pressure to about 80 or 90, and the fluid was about 10. But now with the newer technologies, actually the increase in the pressure is about 16. Although that used to be a lot of talk, at the time of our cataract surgery, the pressure actually in the eye is about 80 or 90 as long as you're doing your phaco. So just to give you an idea. So for me, this actually was not an issue. Although the companies, that was a big issue for them. So now, the other thing that you have to realize is what is a statistical significance versus what is a clinical significance versus what is significant to my patient. So here is what we look at the literature. Is it safer? And this is cumulative dissipated energy. For the cataract surgeons, this is phacoemulsification energy. How much ultrasound are you actually using to remove that lens? And there is a growing evidence in the literature that with the femtosecond laser, you actually end up using less ultrasound, which typically makes sense because you're using a different kind of energy to soften the lens. Thus, you do not need ultrasound to soften the lens farther. Burkhard Dix just shared his data with us, and it is in the bottom, and he said that in about 100% of his cases of a grade 2, and then 98% and 97% consecutively to grade 3 or 4, he has not needed to use ultrasound energy. Therefore, he has 95% of his cases without using ultrasound. Now, phacoemulsification has dominated actually the platforms for cataract surgery for the last about 20 years. Are we seeing the next wave of what we call no ultrasound cataract surgery? Now, is this of an issue? Is this really important? The real question that I have from this is not this slide, but actually this slide, which is it affecting the endothelial cell density? Is it causing significant change? And if you look at it, there's one study that showed yes at post-op month 1 and yes at post-op month 3, but that stopped at that, and we know that actually endothelial cells keep going and they get lost over the next year or 2 and gradually over the lifetime of the patient. But if you look at all of the other studies, they have not shown that femtosecond versus conventional cause statistically significant difference in the endothelial cell density. So whether you use the fancy femto or the regular phaco, there's not going to be a significant difference in the endothelial cell density. How about what I can measure in the clinic, which is central corneal thickness? So how much corneal edema does the patient have? And you realize that by 1 week, by month 1, there's again no difference between the phaco, the conventional phaco, and the femto. How about the wounds? There are a couple animal studies that have showed that the femto will have added stability and reproducibility, and it looks absolutely gorgeous on the OCT. But if you have used the femto, there's actually no evidence that femto wounds are better than your own manual wounds. As a matter of fact, anecdotally, some surgeons will tell you that the manual wounds are actually more watertight. So I have a few cases this Thursday, and I'll tell you that my wounds manually so far are actually better than the femto wounds. This is probably the most important part of this study. And this is, there are some actually from Iceland, there are some from Sweden, there are some from India, and these are population studies. You're talking about 129,000 people. So these are huge epidemiological studies. And these are looking at complications of surgery. The top are all about conventional phaco, and the bottom two are the femto. And the first one is the first 200 series, and the second one is the 1300 following series from the same group. If you look at the anterior capsule tear, you see that actually there is no difference between the two. You look at the posterior capsular tear without loss of vitreous, so vitreous did not come to the front of the anterior chamber, you see that there's also no difference between the two. How about posterior capsular tear with vitrectomy? Again, the numbers, there's no difference between the two. And lastly, lens dislocation, there's really no difference between the two. You realize that at the 2%, I think that has to do with what we call capsular block syndrome and learner effect, so the beginner's effect. So they happen to drop 4 of their lenses, but then in the next 1300, they didn't drop any. So from a safety issue, from complications issue, or standpoint of view, there's really no difference between the femto and the conventional phaco. How about other issues? Anterior tags, anterior capsular tears, posterior capsular tears. Luckily, one thing that you notice in the hands of a novice surgeon, those are relatively high. As you gain more expertise, your complications with the capsule, with the tags and everything get actually better and better. And that is typical. It's just a learning curve. So is it better? And when I'm talking to the patient says, "Doctor, if it's your eye, would you have it?" So would you? No? Another surgeon, would you? No? Do you perform this surgery?
Depends on the surgeon.
Depends on the So today I had, actually my cases, I had a couple LASIKs and then I had about 10 cataracts this morning. So my patient was like, "Doctor, you're wearing glasses, but you want me to have LASIK surgery?" I said, "It's a service that I offer." That's right. So the same thing, like, would you offer it? And is it significantly different? So let's see, actually. If you look at it, no one can argue that a machine-made circle is going to be more reproducible, more centered, and more circular than a human circle. That's common sense, computer generated versus human with an error. So which is true. However, is that significant? Do I have an appreciable difference? Well, yeah, whenever I look at a perfect circle, I'm like, wow, that's a good surgeon, versus something that is a little bit over, I'm like, yeah, it's okay. But when my patient looks at it, actually, aside from vertical tilt and internal comb, which are higher order aberrations, you look at the mean spherical equivalent, the cylinder, the absolute predictive refractive error, uncorrected distance visual acuity, best corrected visual acuity, and you see that the numbers are fairly similar. So to my patient, what my patient sees is no difference in the outcome. Is it cost effective? Well, the laser is about $425,000 plus $40,000 a year plus $350 for every patient. As a matter of fact, there was a study from the Australian group, and they said that the quality improved from the FLACS. If you were to do FLACS, it's $92,000. What cost the FLACS is costing per year. In the best case scenario, it would be 20,000 Australian dollars. Right now, the phaco is about $4,000. So in best case scenario, phaco is 5 times cheaper than the laser. So for sure it has to be cheaper. And I think as probably it's more widespread and whatnot, it will become cheaper as well. Now, here is the second most important slide of my talk. There's no difference in the clinical outcomes as measured by change in visual acuity or occurrence of post-operative adverse events in the performance of this procedure relative to that procedure. Now, interestingly, if you actually look at this, this was published in 1994 by my colleague and good friend, Dr. Oliver Shine, in one of the prestigious journals of ophthalmology, but it was actually comparing phacoemulsification to extracap. So, are we having the same discussion? To give you a historical perspective, when this is an Indian group, it was published in IOVS in 1997, and what they showed was the percent of eyes with complications after phacoemulsification approaches 22%. If you tell your patient that I have 22% complications from cataract surgery, I think they should run as fast as they could. So this is where phaco was 20 years ago. Now the complication rate from phaco is less than 1%. So are we seeing an evolution of a technology that eventually will replace the phaco? The other issue is surgical time. It used to be 1.6 to 2.6 minutes of ultrasound. Now, with my techniques, is about 5 seconds to about 10 seconds if it's a grade 4. And the time of surgery used to be a lot longer. Now it's a lot shorter. So I think the question that I pose to you is, are we seeing an opportunity in every problem, or are we seeing a problem in every opportunity? And this is why we're actually running a study right now at the Wilmer Eye Institute, and I'm the lead investigator for it. I honestly think that the femtosecond is the future of cataract surgery. I'm just not sure it is the present to be widely used by everybody out there. I don't think that financially it makes sense. I don't think that societally it makes sense. But I think from a research and optimization perspective, it makes total sense. I think it is the way that we will be heading. So future or present, this is from the AAO meeting, 45% of physicians already have one. And I think that is more of a peer pressure than actually scientific evidence. 9% will get one in the near future, and thank God 47% are not interested yet. And I don't blame those people. I think that a lot more has to be done before we actually get there. So this will actually summarize the whole talk. My team has created a very innovative solution, but we are still looking for a problem to go with it. So in conclusions, femtosecond is different than conventional phacoemulsification surgery. The question whether is it safer or better remains to be resolved, but as of yet it is not. And I think it has a great promise for the future, but I am hesitant to say that it is for the present. And I thank you, and I'm happy to take questions.
No, unfortunately, we're running into the break time. What I would suggest is those who want to take a break, please go. And those who want to ask questions, please go ahead and ask questions. The lady in the back.
So the quick question is, you mentioned the financial. So there's the financial cost to society, the financial cost to the patient, and the financial benefit to the physician, especially in the world of decreasing reimbursements. So I think we have to be careful when we look at the 45% of doctors who are thinking about getting one. Does that reflect the benefit of safety and efficacy of the procedure, or does that reflect their financial concern for their own future?
That's a beautiful question. Basically, if you actually are looking at a lot of the legislation, cataract surgery was cut by roughly about 13% in the last 2 years. So physicians are basically, what we are getting is about $670 per cataract surgery today, versus our predecessors used to get $2,500 by insurance companies. So there is a significant financial constraint, and the fact that running medicine business today is much, much more expensive than it used to be in the 80s, 90s, or even 2000s, just because you have a lot more things that you have to pay for. So the physicians are feeling the financial strain, but I cannot really look at a patient straight in the eye and I say, this technology is better for you. I just can't. Now, I know some folks in this area, here in the Baltimore region, that will not operate on a patient unless they actually have a femto-laser-assisted cataract surgery. And from a legislative point of view, it is illegal to actually charge a patient extra for the femtosecond laser part of the procedure. So that is bundled. It is part of the cataract surgery. The only time you can charge a patient is if the patient has astigmatism. Or you bundle it with your premium cataract surgeries like, Restore or Crystallens or AMOs. So those are the things that you can charge, but you cannot charge the patient just for the cataract surgery that you want to do a laser with. But I agree with you, it's a financially driven decision rather than a scientifically driven decision as of yet.
Anybody else?
Question in the corner and here.
Okay. I'm substantially a clinician, so from my point of view, actually is not too much cost effective really in the real world. And the other issue is about the training for a new surgeon. My example, I started with a phaco and I switched back to ECC because I started to see a very hard cataract. So the problem with the femtosecond-laser, you're a professor, so you probably also teach surgery, is to grow a generation of surgeons that do learn just a femtosecond cataract surgery, and then we have a hard rock cataract, they cannot do nothing. And this is the other question. In my hands, probably does not change the things too much. I think the beautiful thing of this laser is the capsular axis that is very, very circular and repeatable. And what about the complication? In the first model, I saw really a very bad complication. You know, there was the plasma that was the problem when the energy was not set well. And I saw also some beautiful Italian surgeon in live surgery that ruptured the posterior capsule because of the plasma. Did a hole and all the nucleus goes down. So now it's more safe. I use actually the Victus. They improved a lot. We send the data, but there is a problem of teaching. Except the cost. Actually, it's not cost effective. One moment is the teaching, and the other question is the widespread of this technology. This is good for a university institution or for a good private, but not for the worldwide.
I agree with you. I think one of the things is, as a matter of fact, Dr. Chang did a study with his Nepalese counterparts comparing phaco and extra cap and small incision extra cap, and they showed that phaco and small incision extra cap had exactly the same effect, the same results, the same outcomes after all. The question is, are we actually moving into a world where underserved areas will continue to do 6, and some countries will only do the phaco, and then some other countries will do the femto? I strongly believe that if you are a surgeon, you should still have the surgeon skills and depend less on the machines. Eventually you can go to the machines, but you just like a clinician. The best tool of a clinician is the thing that is in between your ears. That's it. After that, all the machines are great if you know how to use them. If they break, you need to be able to do what you should be doing. With the extra hard cataracts, I actually tend to favor the femto because of just a little bit less ultrasound use. So I like that. In patients who have pseudo-exfoliation, I like the femto because then it's a little bit less on the zonular tension. So in specific cases, I do like the femto. But even in the regular patient, I'm not I think my surgeries as of yet are just very good. But I think it's a matter of time. As I was talking about we have a solution, we created an innovative solution, but we have a problem to go with it. I think the next problem is going to be actually innovative IOLs. So when you have a bioptic IOL where you can capture it right into that perfectly round circular capsulotomy, then the optics can move around a hinge, or polymer-based lens. All of these things will take advantage of this technology, but they are lagging behind as of yet. So I think eventually down the pipeline, 5 years, 10 years, I see it, as the technology catches up with the IOLs, that the femto will have a better use. I did not show you a video of the femto actually being used intraocularly for other reasons than cataract surgery. That is one of my interests that I'm working on, of doing a lot of retained, like Decimase membrane or cornea, femtosecond-assisted cornea procedures. So that is other things that I am working on as well. But I did not, I was running out of time, so I didn't want to show it to you. But I'm happy to show it to you, though. There are 3 questions. Okay.
I have a quick question. Nice talk for the first of all. And I would like to know, in both your studies, when you compare both phaco and FLACS, did you come across, or what is your experience with PCO?
That's a great question, the question with the PCO. And that is, we don't have enough follow-up to actually tell yet, because we just acquired the machine about 8 months ago. So really, PCO can develop typically, within the first 3 months, but it usually like a year, within the first year or two. That's the vast majority. So we're still following those people. One of the thoughts about the femto is because it's a circular capsulotomy and there's a better overlap of the optic and the capsulotomy, then there is less possibility of migration of the epithelial cells and PCO. But as of yet, there's nothing in the literature nor in my hands to show there's a difference. And I think that has to do with IOL designs as well, and and other issues.
Yeah, that's what I was going to ask you. Is the one particular lens is better than the other, or do you have particular preference?
With the femto or just with anything?
Just with anything. Do you prefer some particular lens over the other?
That's a great question. So if I don't necessarily, I do have a preference in certain cases. If somebody has pseudoexfoliation glaucoma or pseudoexfoliation in general, or somebody has diabetes, or somebody who has a Flomax or floppy iris, where I am worried about the zonular strength, I like a 3-piece lens, and I typically like the MA50BM because it's about 13 millimeters, so it's relatively wide, and it's almost like a capsular tension ring. It has within it almost, it mimics what a capsular tension. So I like a rigid and wide IOL for my more complex surgeries. But for a routine case, any of the foldable single-piece lenses will do. For practical purposes here at Wilmer, we use the Alcon SN60W, but that has nothing to do with scientific superiority. That is just vendor-related issues.
Hello. Excellent presentation you have. And but one thing I have questioned that, did you follow the two types of surgery, phaco and femto, if they have glaucoma in future? Either in these two cases?
No. That's a beautiful question.
How long did you follow up?
But the question is, so the real question is, if you actually looked at most of the data, now you have to realize a lot of cataract surgery, after 3 months, they're like, okay, you are done, go to your optometrist, unfortunately, in this country, and that is what happens. We actually, as part of our study, that is something that we will be that we are looking and following, but we are not finalizing our results yet, so I cannot really answer that question for you. That's a very interesting question. There were a couple of studies that have showed increased intraocular pressure after femto. If the time between femto and the cataract is more than half an hour because of the release of pro-inflammatory mediators and prostaglandins into the anterior chamber because of exposure to the lens proteins. But aside from that, there has not been shown anything that that there's a difference in the rate of glaucoma between conventional versus femto. In reality, a lot of the thought about it was like, oh my gosh, if somebody has a glaucoma, is that a contraindication for a femto-based procedure? Because you are increasing the pressure. From a cornea specialist who does DSAC and in end-stage glaucoma patients, and from dealing with a lot of my glaucoma faculty, I can tell you that elevated pressure for that short period of time is not going to snuff your nerve. If you actually look at what your bottle height is at the time of the phacoemulsification, you're going at about 100, 110, which is giving you about 70 to 80 millimeters of mercury. If your surgery is 5 minutes, that's 5 minutes of 70 to 80 millimeters of mercury intraocular pressure. So the surgery itself, the mechanism of the surgery is not going to increase the glaucoma potential. Is there something else that the femto does where it may? I do not know.
Okay. I'm not sure about, perhaps HRT measures the thickness of cornea, right? And HRT.
Yeah, you can, but usually OCT.
That affects the measurement of the IOP. And that varies from population to population.
Correct.
Right. So how to, like in a previous talk, how to maintain, because so many places I see 16 millimeter is the normal. Some people say, no, 10 to 22 is the normal. So how
the Oates study taught us that.
Right,
so basically the Oates study showed that for every 15 millimeters, for every 15 microns of central corneal thickness difference, you have to adjust for 1 millimeter of mercury, plus minus depending on where you are starting with the cornea really. In order for you to have and that has to do with the Goldman tonometry. That does not actually have to do with the tonopens or the eye care anymore. So the eye care actually bypasses that.
Right.
So the newer technology IOP measurements does bypass the central corneal thickness. So it doesn't rely on it as much. But for the central corneal thickness, if you looked at the slide with the central corneal thickness, after 1 week, there's no difference between the two mechanisms, whether you have femto or phaco. So that takes the central corneal thickness measurement error out of the question.
Okay, good. Thank you.
You have a question, and I think, can I say that is the last question?
Yeah, I do believe
I'm happy.
that.
I'm really happy that this is a very
Where we
good
going? Right
group,
here?
but I don't want to steal somebody else's time.
My question was just, it's a little bit similar but different. There's a body of evidence showing now that in mild to moderate glaucoma patients that phacoemulsification drops IOP by 2 to 5 millimeters of mercury.
That is correct.
So my question would have been, do you see a difference between laser and phaco as far as...
In the IOP?
In the IOP lowering effect.
There was a study that just came out last week or 2 weeks ago, and it was in ACTA Ophthamological. And the only reason that it was in ACTA and not in ophthalmology is the fact that it was a negative study. Because if it was a positive study, I think it would have been in one of the bigger journals, unfortunately. And it showed that there's no difference. And there's no difference in the endothelial cell count, and there's no difference in a lot of other things as well. The issue for the IOP, lowering from the cataract, probably the theory is two things. Number one, either there's a very minor micro leak through the corneal incisions that you have created, or the fact that your trabecular meshwork has opened up because you have removed a lens that is about 4 millimeters and you replaced it with an IOL that is 0.5 millimeter. So the ciliary body diaphragm actually moves back, and therefore you're opening your trabecular meshwork and potentially increasing your filtering. So those are the two predominant theories about why IOP is lowered after glaucoma. But it is established that, on average, it's about 3 millimeters of mercury just from the cataract surgery alone. That's correct.
Well, thank you very much for a very exciting talk and discussion.
Thank you.